Hello. All right, there you go. Cool. All right, for the those on Zoom, apologies for the lack of volume. I think the mic situation has been remedied. We are now moving into assessing nutritional status and malnutrition risk. So I know for me, obviously I'm a first-year fellow, so I'm sure I, don't do a lot of things perfectly right, but I actually have not really done this on many patients, and it was somewhat foreign to me. I think our kind of colleagues in nutrition probably do this, but I had not personally. And just in the box, I just wanted to introduce the two main societies we're going to be referring to. We'll get into it a little bit more, but it's the ASPEN and the ESPEN societies, ASPEN being the American Society for Parenteral and Enteral Nutrition, and then ESPEN being the European Society. SCCM kind of endorses ASPEN and is closely tied to them in terms of their recommendations on nutrition and critical illness. And for the sake of the two words being almost identical, I'm just going to call them the Americans and the Europeans going forward because it's just easier to differentiate. So the first thing I think we often think about when assessing nutritional status and malnutrition risk are kind of, those classic serum markers, albumin, prealbumin, CRP, and all that. And I think a lot of us probably know this at this point, but when they actually study this in critical illness, serum markers are not at all adequate and don't reflect nutritional status in our patients. They're phase reactants, they have highly variable levels in inflammatory states. So recommendation is to not use serum markers to any degree when assessing nutritional status or even protein status in these patients. This was interesting. These were in kind of the guidelines, which was imaging modalities to assess nutritional status. And as with many things these days, ultrasound has kind of come into the light as a possible means to do this bedside. And you can actually measure the muscle mass, which we have a slide coming up looking at that. And then CT scan, they said, can precisely quantify skeletal muscle mass, although I think this is probably, a lot to send a patient to CT scan to do this. So I think that's probably not very practical. As for ultrasound, this was just one protocol. So there's actually a fair amount of kind of new studies out there looking at different protocols for how to do this. And this was one of the protocols published. You can see 3 pictures there. And in each picture, there's the femur, the anechoic area. And then above that, there's 3 layers, being the vastus intermedius, rectus femoris, and subcutaneous fat. And on the far right is someone with no malnutrition risk. And you can see that the quadriceps thickness, which is listed at the bottom of the graphic, is the thickest. And then the echo intensity is the lowest. And as it travels to the left, these patients have more malnutrition risk, and you can see those 3 layers get thinner, and then the echo intensity of the quadriceps muscle goes up. So this is something interesting that I think that there's lots of people looking at in the nutrition world as kind of an easy, non-invasive bedside way to assess malnutrition risk, although I don't know anyone that has actually done this practically bedside. All right. This transitions into the way that I think at least our nutritionists tend to assess nutritional status and malnutrition risk in our patients, which are kind of these screening tools. There's a whole bunch of them. Here are the kind of the 4 main ones, but the one that is endorsed by the American and Europeans is the Nutric score. It looks like it's been the most heavily studied and does correlate with disease severity and nutritional status in the critically ill. So this is kind of a score that's going to come up a lot when we talk about the different guidelines and evidence as a cutoff for malnutrition in critical illness. So what is in the Nutric score? Just quickly, you can see it's age, Apache 2, SOFA score, number of comorbidities, days from hospital to ICU admission, and then they do have interleukin-6 levels. They say that, not many people send these off. So the bottom table is how you would assess it without interleukin-6, and a Nutric score above 5 are patients who are likely to benefit from kind of aggressive nutritional therapy. So these would be high malnutrition risks. And again, just tuck that away in your brain because it'll come up when we actually talk about some of the practical guidelines and literature on nutritional status. So this is something obviously we could all do. I personally have never done it. I think our nutritionists probably do this more than we do, but it'd be an easy score that we could calculate on our patients. And then the last way that they say you can do this is they actually, the European guidelines have this fancy table broken into phenotype criteria and etiology criteria. And you can see moderate malnutrition, severe malnutrition on the far left. And then within that, you need one phenotype criteria and one etiology criteria to fit within moderate or severe to be considered either moderate or severe. So it's just another table you can use. So why are we even talking about this? Again, I haven't done it. I don't know if many of you have done it, but technically the recommendation by both the Europeans and Americans is that every patient should have some form of a nutritional screen within 48 hours of admission. And again, it typically is the Nutrix score, but you technically could use any of them. So that is kind of at least formal guideline wise what is recommended in our critically ill patients. So then the last part of this kind of beginning half of the lecture is just a brief touch on calculating nutritional needs. We're not going to spend a lot of time on this. I don't anticipate that any of us are going to sit there and, do a whole bunch of math that the nutritionists are doing anyways, but I do think there's a few things that are just helpful to understand. One being indirect calorimetry. Oh, it looks like the format got a little weird, but indirect calorimetry, this is the gold standard per the European and American guidelines on how to assess caloric needs in our critically ill patients bedside. This is a picture of what it looks like. The way it works is that the indirect calorimetry measures the respiratory gas exchange to estimate the energy metabolism. And it does that under the assumption that on the cellular level, when you're producing ATP, byproducts are water and CO2. And then to produce that ATP, you need oxygen as well as substrate to produce the energy. So it looks at the oxygen consumed in the CO2 expired and then makes kind of an estimate on the energy metabolism in the patient in real time right there. It uses this equation. I just wanted to put it up there for the sake of having it up there where you have the VO2 and VCO2. Of note, it is the gold standard, but it does have a lot of shortcomings, especially in the ICU. It can be inaccurate with air leaks. It can be inaccurate in patients on ventilators, patients on CRRT, patients with excessive movements of sorts. So, it's not foolproof, but it is technically the gold standard. And I don't know if that would come up in boards, but it would be recommended for critical care patients or patients in the ICU. All right, so what do we typically use? We typically use these calculations. There's two different ones, the energy need and the protein need. When they look at these calculations compared to indirect calorimetry, the gold standard, they're fairly inaccurate. Studies show that they're just 40 to 75% accurate when compared to the gold standard, but they're kind of obviously much more simple and straightforward, so they are most often used. So the energy need is 25 to 30 kcals per kilogram per day. One thing to note is this should be based on dry weight, which is obviously unachievable in some of our patients who haven't been to the hospital with a dry weight recorded. And then as for protein, it's a separate need. So for the energy need, you should take into account things like dextrose-containing solutions, lipid-based medications. And then the protein need is 1.2 to 2 grams per kilogram per day. And then there's lots of times this needs to be adjusted. Obese patients, burn patients, patients on CRRT, all of them need increased protein intake. So you kind of got to look at all the caveats. And again, I don't anticipate, we're going to be sitting down doing this math ourselves, but I think it's at least helpful to understand what's going on behind the scenes when we kind of get recommendations from our nutritionists. All right, so that leads into kind of the more clinically applicable portion of the presentation, which are actually the practice guidelines and evidence behind them. There's both the American and European guidelines. The American guidelines, I believe, were from 2017 or the most recent. The Europeans are from 2019. And I tried to choose kind of guidelines and evidence that are most applicable to our clinical practice in the ICU. Obviously, there's a ton of stuff on like micronutrients and that type of thing, which I kind of veered away from because I thought it'd be less relevant. So there's, I think, 5 or 6 kind of questions that I look to answer. Any questions thus far? I know it's kind of a lot. I tried to fly through that. Cool. Okay. So the first question I tried to answer was, what route of nutrition, oral, enteral, or parenteral, is recommended in critical illness? And to do this, both the Americans and Europeans agree that oral, if possible, is the go-to route that you should always use. But obviously many of our patients can't get oral nutrition, in which case both the American and Europeans state that enteral nutrition should be used over parenteral nutrition. The Americans put low to very low evidence on this, and there's not a lot of studies that have shown a big effect here, but the studies out there, at least the studies out there when the guidelines were established most recently, did consistently show decrease in infectious morbidity, and some of them showed a decrease in ICU length of stay. when you gave enteral nutrition over parenteral nutrition. Now we'll touch on this a little later. There's some more recent studies that kind of rebuke that a bit, so it's falling out of favor a touch. But the guidelines thus far still say enteral nutrition over parenteral nutrition. This is a meta-analysis that was put out by the Americans that show that infectious complications, they favor enteral nutrition over parenteral nutrition. And then you can see these are the Europeans have a very similar meta-analysis that looks at infectious complications. And they looked at it both in the ICU patients and non-ICU patients. And again, that favors early enteral nutrition. The Europeans give this grade A evidence, whereas the Americans gave it a little lower stint of evidence. But again, if we look at the studies, like for the American meta-analysis, the latest one is from 2011. So not a lot of the newer data is on here, which kind of transitions into just one paper that comes up frequently when I was reading about all this, and it's the Nutriria 2 study that came out in 2017. It was published in Lancet. And it was a randomized control multi-center trial. It looked at mechanically ventilated patients who are also on vasopressor support, which is interesting to note. And they looked at enteral nutrition in these patients versus parenteral nutrition, started within 24 hours. They enrolled 2,400 patients. And I put the results down there. Essentially, the mortality and the infectious complications were not different between the two groups, which if we remember, the big thing that they were finding in the meta-analyses were an increase in infectious complications in those that got parenteral nutrition. So this study, which was one of the bigger studies done recently, showed that there was not a difference in infectious complications. Now, we'll talk about this a little later. Enteral nutrition did have more vomiting, diarrhea, bowel ischemia. And again, we have to note that these patients were on vasopressors, which obviously is significant. But this was one of the studies that people are kind of pointing to as a possible rebuke for enteral nutrition being better than parenteral nutrition, just in general in our critically ill patients. All right, so we know now that at least the recommendation is to start enteral nutrition, but when should we start it in our patients? So the Americans and Europeans both state that early enteral nutrition should be started, so within 48 hours of admission to the ICU, arguments being that it supports gut integrity and decreases the risk of infections, multi-organ dysfunction, and there's even been some mortality benefit shown. So here's a meta-analysis from the Americans that show that early enteral nutrition is actually associated with a decreased mortality as compared to late. And then there's a second meta-analysis done that showed a decrease in infectious complications in those started on early enteral nutrition. So pretty significant. I think the argument here is most of our patients, barring some of the things I'll state here in a second, should be started on enteral nutrition within 48 hours. And I think that probably does affect outcomes. Now, the caveat to all this, which is published in the guidelines, is, they say if there's uncontrolled shock or severe hypoxemia, upper GI bleeds, abdominal compartment syndrome, all those other things, that obviously the enteral nutrition should be delayed. But besides that, early enteral nutrition within 48 hours seems to decrease mortality and infectious complications, at least per these meta-analyses and the guidelines published. All right, so we're starting enteral nutrition. We're starting it early, but how much should we feed patients? Should we start early nutrition and titrate to full feed super quickly? Should we start nutrition and leave it on trophic or trickle feeds for a period of time? How should we progress patients with their feeds? The Americans and Europeans in their guidelines kind of approach these differently. So trophic feeds, kind of what we call trickle feeds, are defined as 10 to 20 cc's per hour, which many of us probably know. In the American guidelines, they actually don't give any specific recommendations on just the critically ill general population. What they do, though, is talk about kind of some subgroups. So the patients with acute lung injury and ARDS, they say that you can do either trophic feeds or full nutrition because the outcomes are similar. And this will come up at the very end, but what they're referring to is a trial called the Eden trial that looked at patients with ARDS and essentially found that you could either do trophic feeds, so leave them on trickles, or progress to full feeds, and that the outcomes were the same in terms of infections, mortality, and event-free days. Those with high-risk malnutrition, so this Nutrix score is coming up again. So if you have a Nutrix score greater than 5, the recommendation is actually to advance to full feeds within 48 to 72 hours. So that'd be greater than 80% of your goal. And this is based off of a study called by Halen et al., where they looked at those with Nutrix scores above 5, Nutrix scores less than 5, and found that if you progress to full feeds early, there was a decrease in mortality in those with the Nutrix scores above 5, but no difference in those with a Nutrix score less than 5. So it does seem like there could be a mortality benefit in progressing malnourished patients to full feeds more quickly, which, you know, conceptually makes sense, but the literature bears it out as well. And then the last one that the Americans talk about is sepsis or septic shock. And their recommendation is actually to just do trophic feeds for 48 hours. And that's based off of indirect calorimetry data in septic patients that shows that they actually only need anywhere from like 25 to 60% of their typical resting energy expenditure during the acute phase of sepsis or septic shock. So in those patients, kind of continuing trickles would be the recommendation, at least for the first 48 hours. The Europeans, instead of diving into any of the kind of subgroups, just say for the general population in the ICU that enteral nutrition should not be used immediately. Rather, you should prescribe it and kind of up titrate it in the first 3 to 7 days. So I think what we grasp from this is in those not at high risk for malnutrition, you have a little bit of time. You can kind of progress from trickle feeds to full feeds more slowly, but in high risk malnutrition, I think progressing those to full feeds more quickly would be in line with the recommendations. So kind of a little all over the place, but they covered a lot of groups between the two of them. All right, so we now have covered oral nutrition is best, enteral and parenteral nutrition may be equivalent, but the guidelines would recommend enteral nutrition over parenteral nutrition. We've talked about starting that within 48 hours, and then we've talked about how to progress those to full feeds depending on different subgroups. The next question that I thought was interesting was, should we be giving this enteral nutrition gastrically or kind of post-pylorically to the small bowel? And when I was reading about this, I personally, at least in the MICU, have not put anyone on post-pyloric feeds just for the sake of doing it beyond kind of an anatomic reason. But the Americans and Europeans both actually recommend doing this in a lot of patient populations that we probably see. So they both say that gastric access should be the standard approach to enteral nutrition. They mostly have kind of expert consensus as the evidence behind this. And they essentially acknowledge that the reason they put that in there is because there's often a delay to nutrition. When you try to get post-pyloric access, it's obviously technically challenging and, you know, can run into issues. But they say that you should divert to post-pyloric feeds, and those at high risk for aspiration or those with intolerance to gastric feeds. And this sounds reasonable, but when you look at the aspiration risks that they publish, it's, you know, a huge number of our patients that we're seeing, right? I would argue, you know, the vast majority probably have some of those aspiration risks, which per the guidelines would suggest you should consider diverting post-pylorically. Now, with this being said, when they actually did meta-analyses looking at why they're recommending this, there was no difference in like clinically relevant outcomes: mortality, ICU length of stay, hospital length of stay, duration of mechanical ventilation, or even time to goal enteral nutrition. What they did find, though, was that small bowel feedings did have in the meta-analyses a decreased risk of pneumonia. And then they also found, the Europeans published, that they felt the meta-analysis showed an increased tolerance of feeds in those that got post-pyloric feeds. So although the recommendation would be to divert post-pylorically in patients not tolerating gastric feeds, or in patients at high aspiration risk, the actual clinical outcomes and the evidence out there are not super robust. You know, maybe an increased risk of pneumonia if you feed gastrically in those at high aspiration risk, but then there's no kind of association with other significant clinical outcomes. So I guess take the guidelines for what they're worth based on the evidence. All right, so we are going to, you know, start enteral nutrition. We're going to do it within the first 48 hours. We're going to progress to full depending on the patient population. And we're going to do it in the stomach, unless you want to get fancy and try to go post-pyloric and somewhat high aspiration risk. But as we progress these patients, should we be starting parenteral nutrition on patients that, one, are not tolerating their enteral nutrition, or two, cannot be progressed to full enteral nutrition in an appropriate time frame? So I left all the words on here because I know it's a busy slide, but I wanted you guys to be able to kind of read what exactly they said. And they essentially say that in those at low risk of malnutrition, so that Nutrix score again, less than 5, you shouldn't be starting any parenteral nutrition within the first 7 days that the patient's there. The Europeans put this at 3 to 7 days. The Americans say 7 days. But they go on to say that in those at high risk for malnutrition, so again, that Nutrix score, you actually should consider starting parenteral nutrition immediately in those that are not tolerating enteral nutrition, which is interesting. I don't think I personally have done this, in the acute phase of critical illness, starting parenteral nutrition and those that aren't tolerating enteral nutrition. Again, I hadn't even really calculated a Nutrix score, so I guess I'm way behind the 8 ball. But the recommendation would be from the American guidelines to do that. The Europeans have softer wording, and they said just consider starting parenteral nutrition early rather than immediately. But both societies put out there that in those severely malnourished based on this Nutrix score who are not tolerating enteral nutrition, you should be starting parenteral nutrition early on in their course. Last point is in those unable to meet their energy needs, they essentially say that by day 7, if they're still not meeting at least 60% of their energy or protein needs, you should be supplementing with parenteral nutrition in addition to their enteral nutrition. The Europeans are a little softer, and they say just think about it on a case-by-case basis and make sure you're optimizing all potential ways for them to tolerate their enteral nutrition. So I thought that was interesting. That's not something I've really done, but the American guidelines, which again are endorsed by SCCM, would suggest that I maybe should be starting parenteral nutrition on more of my patients earlier on. What is this based off of? There's a lot of studies. I just want to put one on here because when I was looking at kind of questions in different question banks, they talk about some of these trials. The Enteric trial is the big one that kind of talks about late versus early initiation of parenteral nutrition in the not malnourished. And it was a randomized multi-center trial looking at late or early. It had over 2,300 patients. Early was within 48 hours and late was after day 8. And what they essentially found was that there was actually late initiation, so after day 8 of parenteral nutrition, actually had faster recovery and fewer complications as compared with early initiation, which is why if we go back for this first point, the Americans recommended those not malnourished to wait until day 7 before starting parenteral nutrition, which again is based off of this study. Now there's a number of other studies the guidelines talk about, and they're all kind of only peripherally relevant studies that they kind of extrapolate some of the recommendations from. So again, just acknowledging that the evidence in all this is a bit discordant and soft, but this is kind of the most well-established trial that looked at this, which is where they got that wait till day 7 recommendation from in those not malnourished. All right, we're getting closer, I promise. So the next question I asked, which, I think we all know our protocols here, but should gastric residual volumes be used to gauge feeding intolerance? And other way. Luckily, the evidence agrees with what we do in our shop. The recommendations are in the top right. So they essentially say that you should not be using gastric residual volumes. And if you decide to go against that and to use them, then you should use a cutoff of 500 as like a not tolerating feeds, which is compared to the kind of, I guess, traditional or old way of thinking, which was like cutoffs from anywhere from 50 to 200. Where they got this from was this Regain study, which is the one that they mainly talk about. And the bottom portion is just the point to look at. So in the study, they essentially looked at 325 patients on vents in Spain, and they used gastric residual volumes of either 200 as a cutoff or 500 as a cutoff, and they essentially found that duration of mechanical ventilation, ICU length of stay, frequency of pneumonia, all that were similar between the two groups, so it did not matter. So from that, they said, if you're gonna do it, you should use 500. But since this time, there's actually been a number of other studies that have showed that even using 500 compared to not using gastric residual volumes at all, there's no difference in outcomes looking at these same endpoints that this regain study looked at. And it's important to note, that checking gastric residual volumes is a nursing burden. It can lead to, clogging of their enteral devices. It can lead to not getting up to goal enteral nutrition more often. So there are shortcomings to it. So luckily the evidence agrees with what we do, which is that you shouldn't really be checking gastric residual volumes as a mean to gauge feeding intolerance. We should be doing all those other clinical things. And if we do check them, 500 would be the cutoff. All right, I think I have 2 more questions to be answered here. So the next one is, should prokinetic agents be used with feeding intolerance or those at risk of aspiration? And the Americans and Europeans kind of approach this differently. So the Americans talk about that high risk of aspiration group, which we remember all the patients at risk of aspiration, which is most of our patients. And they actually go out to say that, any patient at high risk for aspiration getting gastric enteral nutrition should actually be empirically started on prokinetic agents when feasible, which is not something I've done because I think the majority of my ICU patients would then be on prokinetic agents. They say that you can use erythromycin, that was the dosing they published, or metoclopramide. But obviously this is not without risk, right? So both of these medications have side effects, QTC prolongation, metoclopramide with tardive dyskinesia, erythromycin with tachyphylaxis and cardiac toxicity. So they acknowledge it's based on low evidence. I'll get into the meta-analysis in the next slide, but they technically recommend guidelines. Anyone with high aspiration risk should be considered to be empirically started on a prokinetic agent. The Europeans essentially say the same, but they say erythromycin is really the only one that works. And they did an analysis to support that. So this is the meta-analysis. I think this one was published by, the Americans. And the evidence or the reason why they say that is because if you start prokinetics, you have lower gastric residual volumes, which they just finished telling us that we shouldn't be checking gastric residual volumes. So take that for whatever it is worth. The Europeans say that when they actually looked at this, they found that erythromycin was associated with less feeding intolerance, but actually metoclopramide was not, which is why they actually only recommend using erythromycin if you're going to do it in the European guidelines, whereas the Americans say either metoclopramide or erythromycin. So again, recommendation is to do it, but I think there's probably not a lot of good evidence, and there's obviously the drugs aren't without side effects. So just something to consider, pros versus cons. All right, last question is, should enteral feeds be started in those on vasopressors? This was a more interesting question to me. I think we probably get a lot of variability in how different staff and fellows approach this. So I wanted to kind of just look at what the formal guidelines said and then what the evidence behind them are. So again, a busy slide, but I think the wording of the guidelines is important because it's a lot of soft language. So the Americans essentially say that, in the setting of hemodynamic compromise, you should not be giving enteral nutrition until the patient is fully resuscitated or stable, whereas those undergoing withdrawal of vasopressor support, so with improving hemodynamics, may be considered with caution, and that's expert consensus. But then they go on to say that, if you withhold enteral nutrition in those hypotensive, enteral nutrition should be withheld in those that are hypotensive, have vasopressors being initiated, or are requiring escalating doses. And they have like a little caveat, little side thing in the guidelines that talk about this retrospective review. And the retrospective review actually showed that in those on low dose vasopressors, there was a decrease in ICU mortality and overall hospital mortality if you started enteral nutrition. So it's kind of funky. They put out kind of the soft language of maybe don't do it or maybe think about it, but then the study they quote actually showed improved mortality if you were on low dose stable vasopressors. The Europeans are still soft in their verbiage, but they're a little more firm in saying that, if there's uncontrolled shock or if tissue perfusion goals are not being reached, then maybe you should delay enteral nutrition. But you should start low dose enteral nutrition as soon as shock is controlled, even if the shock is controlled with vasopressors. So they're a little more firm in saying, we should be putting patients on enteral nutrition who are on vasopressors if that shock is controlled. Now, keep in mind, again, the Europeans published their guidelines in 2019. I think it was the Americans most recently, or 2017. So there's some more recent data since then. And we're going to talk about just a few papers quickly that kind of drive through these points. So the first one, this might look familiar. This is that Nutria 2 study that we talked about earlier, published in Lancet. And as a reminder, it was like 2,400 patients. They were on vents and also on vasopressors. And it was looking at parenteral nutrition versus enteral nutrition with no difference in mortality or ICU-acquired infections. But the thing that they note, and maybe I should have put a little arrow on here, maybe I did. Oh, look at that, was that there was increased bowel ischemia in the group that got started on enteral nutrition, 2% versus less than 1%. And this was first kind of put forward as maybe a reason not to start enteral nutrition. But when you actually dive into the study, and what a lot of the kind of editorials and reviews talk about is that these patients actually on average were on a very large amount of vasopressors. So the average amount of vasopressors the patients were on were, I can't scroll down on my notes, but it was for a 70 kilogram individual, 37 micrograms of Levophed, and that was on average. So half the patients were even higher than that. So this was a really significant amount of vasopressors. And even with that, the mortality and ICU-acquired infections were different. There was just more bowel ischemia. So what studies have come out since then? This is another one that they often point to, is published in Clinical Nutrition. And it was a massive study that looked at actually over 52,000 patients in shock. And they divided things into two different groups. So group one was early enteral nutrition, so started within 48 hours. Group 2 was delayed enteral nutrition, which was anytime after 48 hours and upon stability of shock, which was kind of soft verbiage and not well defined. And then they divided it further into those on low dose vasopressors, which was less than 0.1 micrograms per kilogram per minute, which if we think someone 70 kilograms is average, that'd be 7 mics. Obviously, a lot of our patients, are more than 70 kilograms. So there was medium dose vasopressors, which was up to 0.3 micrograms per kilogram per minute. Or if we use that 70 kilo person, it would be 0.3 times 70. What does that equal? 21 micrograms of Levophed. And then high dose vasopressors, which is greater than 0.3. And what they actually found was that in the early enteral nutrition group, so those started on enteral nutrition within 48 hours, independent of their vasopressors, there's actually a significantly lower 28-day mortality in the low dose and medium dose group. So up to 21 micrograms. And, if we're thinking someone is a 70 kilogram person, the high dose group didn't have an increased mortality. There just was no difference in mortality between the two groups. So this was kind of a big study that drove home the point that not only may this be safe, but it actually might improve outcomes if we do nourish some of these patients on vasopressors. And then this was just a recent kind of editorial review published in 2020 in Critical Care Medicine, which was titled "Enteral Nutrition Can Be Given to Patients on Vasopressors." And they do a nice job of kind of just going through the data. And the take-home points are that, kind of like we talked about, more recent data, some data published after those guidelines, suggests that enteral nutrition can be delivered safely to patients on vasopressors, and beyond that may actually benefit outcomes if you start that enteral nutrition early. The authors in this study suggest a cutoff of between 0.14 and 0.3 micrograms per kilogram per minute, which again, someone who's 70 kilos, that would be 10 to 21 mics of Levophed. They do say that most studies suggest that you should just do trickle feeds, not progress to full feeds, although they do say that some of the studies did do full feeds without any worse outcomes. And then, all these papers and guidelines and stuff all say you should be constantly monitoring these patients for signs of feeding intolerance to suggest there could be something like bowel ischemia, which I think is all a given. So it seems like, although the recommendations by the Europeans and Americans are kind of soft in their language, that more recent data suggests that we probably should be nourishing these patients on vasopressors, probably definitely low dose, probably medium dose, and I guess the cutoff is still up in the air, and that might actually benefit mortality rather than worsen it. Although formal guidelines we already talked about don't necessarily take that firm of a step. So take home points just on the guidelines and evidence. I don't think I want to read all these out loud, but if anyone wants them, I can send it to them. I think you guys can all read too. But it just goes over what we talked about, starting enteral nutrition over parenteral nutrition, although more recent studies show equivocal outcomes between the two. Enteral nutrition should be started early, mostly at trophic feeds, progressing more quickly in those malnourished and progressing more slowly in those not malnourished. Gastric feeds are recommended, although guidelines would say high-risk aspiration, you should consider post-pyloric with the understanding that the clinical outcomes aren't really different between the two. Prokinetic agents should be considered empirically in those at high risk, but again, no difference in clinical outcomes. And then just a few more. Parenteral nutrition shouldn't really be started until day 7 unless you're malnourished, in which case you should consider starting it more quickly, as well as those at day 7 not meeting their energy needs. Gastric residual volume shouldn't be used. And trophic feeds should be started in those unstable doses of vasopressors, potentially even on moderate or higher doses, and there might actually be a mortality benefit. Where am I doing? 45. All right. I did just want to briefly talk about COVID, and there's one practice question and then we'll be done. So I was hoping there'd be this whole, slew of how to, provide nutrition to COVID patients and that it maybe would be different and all of that. And this was a review published in, did I not put where it was published? One of the ICU journals, and they had this nice graphic. And if you actually look at the graphic, it is pretty much saying that those with COVID are high risk for malnourishment. And then the recommendations are pretty much what you would do for anyone high risk of malnourishment. So I wasn't going to belabor the point too much, but I think the take home is our COVID patients tend to be high risk for malnourishment. And then we should, address their nutrition kind of down that pathway, which we've talked about. All right, last but not least, brief question. So these are my last slides. I have the chest Qbank and I was scouring it looking for a question related to nutrition, and I found one. So here it is. 48-year-old overweight woman with PCOS, hypertension, renal calculi, came in right flank pain, dysuria. Summary statement would be she had pyelo with obstructing nephrolithiasis, went to the OR. Post-operatively, she was in shock and hypoxemic, started on vasopressors, intubated, went to the MICU. Chest radiograph and clinical findings would show ARDS. Do you guys want to read it longer? Was that a good enough summary? Which of the following is true regarding the nutrition in this critically ill patient? You guys can just shout it out when you decide. One of these is like the guidelines suggest one thing, the more recent studies suggest something different, and they go by the more recent studies. So you might choose that answer, but it's not the right one. This is like a very nitpicky question, but I would have chosen another one, but it was literally the only nutrition question in the whole Qbank that I could find. Y'all are running out of time. Choose a letter. All right, I got C's and then a D. All right, I didn't fail miserably. So trophic rates of enteral nutrition have similar outcomes in those with ARDS based on that Eden trial that showed similar outcomes, which we talked about in one of the many previous slides. Again, if you look B, I think it was B. No, what was it? I think A was the one where it might seem like it's right because some of the guidelines kind of suggested that, but more recent studies show that, not as slam dunk. So C is the answer. All right, here are my citations. Thank you. Questions? So there are formal guidelines on bolus versus continuous feeds. The summary statement would be that continuous feeds are preferred. Bolus feeds have more association with diarrhea and feeding intolerance and such. But if you're to a point where your patient may be transitioning to a level of care or different place for their care that would benefit from bolus feeding rather than continuous, then you can try to transition them. But much beyond that, there was more kind of soft complications. So not like definitive clinical outcomes, but soft complications with bolus feeds compared to continuous. Anyone else? All right, that's all I got. I need to.
That was great, man.
Thanks.
You said it was a tough topic, but you smashed it. Some in the chat.
Oh,
No,
I didn't even look in
no,
the
it's just
chat.
we can't hear, can't hear.